Late-onset sepsis represents a fundamentally different entity from early-onset disease, requiring clinicians to shift their thinking from maternal-fetal transmission patterns to hospital and community-acquired infection models. This temporal distinction at 72 hours marks when the pathophysiology, microbiology, and clinical approach change dramatically. The defining timeline extends from 72 hours through the first week of life, though some definitions extend to 28 days or beyond. This timing reflects the transition from vertical transmission during delivery to horizontal transmission from environmental sources. Understanding this shift helps explain why late-onset sepsis patterns differ so markedly from early-onset disease we've been discussing. Horizontal transmission becomes the predominant mechanism, meaning organisms reach infants from external sources rather than maternal flora. This fundamental change creates entirely different microbial patterns and risk factor profiles that guide prevention strategies and empirical antibiotic selection. The distinction between hospital-acquired and community-acquired late-onset sepsis reflects where exposure occurs and which organisms become likely. Hospital-acquired infection develops in infants remaining in intensive care environments, typically involving multi-drug-resistant organisms and healthcare-associated pathogens. Community-acquired infection occurs in previously discharged infants who return with sepsis, often involving typical community pathogens. Incidence patterns reveal the inverse relationship with birth weight that characterizes neonatal intensive care epidemiology. Term infants rarely develop late-onset sepsis, while extremely low birth weight infants face attack rates exceeding 20%. This dramatic gradient reflects the complex interaction between immune system maturity, invasive procedures, and prolonged hospitalization required for survival in the smallest infants. Prematurity emerges as the strongest independent risk factor because multiple vulnerabilities converge in preterm populations. Immature immune systems cannot mount effective responses against environmental pathogens. Compromised skin integrity provides portal of entry for normally harmless organisms. Prolonged hospitalization increases exposure time to resistant hospital flora. Central lines and mechanical ventilation represent the major iatrogenic risk factors, creating direct pathways for organisms to bypass normal host defenses. Each invasive device provides a foreign body surface where bacteria can establish biofilm formation, leading to persistent infection sources that resist both immune clearance and antibiotic therapy. Prolonged hospitalization and broad-spectrum antibiotic exposure work synergistically to select for resistant organisms while suppressing normal protective flora. This creates the perfect environment for multi-drug-resistant pathogens to flourish and establish infection in vulnerable hosts. Looking at the pathogen distribution in late-onset sepsis, we see a completely different microbial landscape compared to the early-onset patterns we've been studying. This shift reflects how horizontal transmission and device-related infections create entirely new challenges for neonatal intensive care. Coagulase-negative Staphylococcus dominates late-onset sepsis, accounting for approximately 50% of infections. These organisms, primarily Staphylococcus epidermidis, represent normal skin flora that become pathogenic in vulnerable neonatal populations. Their predominance reflects several key factors: ubiquitous presence on healthcare workers' hands, remarkable ability to adhere to medical devices, and capacity to form biofilms on foreign surfaces like central venous catheters and endotracheal tubes. Understanding why coagulase-negative Staphylococcus succeeds in this environment requires appreciating biofilm formation. These organisms produce extracellular matrix substances that create protective layers on device surfaces, making them nearly impervious to both immune system clearance and antibiotic penetration. Once established, these biofilms serve as persistent infection sources that continuously seed the bloodstream. Staphylococcus aureus, including methicillin-resistant strains, represents the more virulent staphylococcal pathogen in late-onset disease. Unlike coagulase-negative species that primarily cause indolent infections, S. aureus produces aggressive disease with rapid clinical deterioration. MRSA prevalence in intensive care environments creates additional therapeutic challenges requiring vancomycin or other advanced antimicrobials. Gram-negative organisms constitute about 33% of late-onset sepsis, representing a dramatic increase from early-onset disease patterns. E. coli, Klebsiella, Enterobacter, and Pseudomonas reflect the hospital environment's selective pressure for resistant organisms. These pathogens often demonstrate multi-drug resistance patterns that complicate empirical therapy decisions. Candida species emergence in late-onset sepsis represents a unique aspect of neonatal intensive care epidemiology. Fungal infections typically occur in extremely low birth weight infants with prolonged antibiotic exposure, multiple invasive devices, and compromised immune systems. The mortality and morbidity associated with neonatal candidiasis make prevention through antifungal prophylaxis an important consideration in highest-risk populations. Enterococcus, including vancomycin-resistant Enterococcus, reflects the consequence of broad-spectrum antibiotic selection pressure in intensive care environments. These organisms demonstrate intrinsic resistance to many antibiotics and can acquire additional resistance mechanisms, creating therapeutic challenges. The appearance of Group B Streptococcus in late-onset disease represents a distinct entity from early-onset GBS. These infections typically occur beyond the first week of life and may represent delayed manifestation of early acquisition or true nosocomial transmission. The overarching principle emphasizes that device-related infections predominate in late-onset sepsis, making prevention strategies focus on meticulous device care, infection control practices, and judicious antibiotic use, rather than the maternal screening and intrapartum prophylaxis strategies effective for early-onset disease. Late-onset sepsis manifests with a distinctly different clinical pattern compared to the explosive presentations we see in early-onset disease. Understanding these differences helps clinicians recognize infection in vulnerable NICU populations, where subtle changes may represent life-threatening illness. The insidious onset represents perhaps the most challenging aspect of late-onset sepsis recognition. Unlike early-onset disease that typically declares itself within hours through respiratory distress or cardiovascular collapse, late-onset infections develop gradually over days. This slow progression often occurs in infants who already demonstrate baseline abnormalities from prematurity or ongoing medical conditions, making subtle deterioration difficult to detect. Temperature patterns show interesting differences from early-onset presentations. While hypothermia still predominates in preterm infants, fever actually occurs more commonly in late-onset sepsis than in early disease. However, temperature remains an unreliable indicator because many septic infants maintain normal readings throughout their illness. The key lies in recognizing temperature instability rather than focusing on specific values. Feeding intolerance emerges as one of the earliest and most consistent signs, appearing before other systemic manifestations become apparent. This presents as increased gastric residuals, abdominal distension, or refuse of previously tolerated volumes. The mechanism involves inflammatory mediators disrupting normal gastrointestinal motility and function. Apnea and bradycardia episodes increase in frequency and severity, particularly in preterm populations where baseline episodes may already exist. The challenge involves distinguishing normal prematurity-related apnea from sepsis-induced episodes. Generally, increasing frequency, longer duration, or requiring increased intervention suggests infectious etiology. Glucose instability represents metabolic dysfunction from inflammatory stress. Both hyperglycemia from stress response and hypoglycemia from increased consumption can occur. Previously stable glucose control patterns that suddenly require frequent adjustments often signal developing sepsis. Thrombocytopenia develops through multiple mechanisms, including consumption, sequestration, and decreased production. Platelet counts below 100,000 particularly suggest fungal infection, especially Candida species. This association becomes important because fungal sepsis requires entirely different therapeutic approaches. The most concerning clinical pattern involves deterioration despite appropriate antibiotic therapy. When bacterial cultures remain negative and clinical status worsens after 48 hours of broad-spectrum antibiotics, fungal infection becomes highly likely. This scenario demands immediate antifungal therapy because delayed treatment dramatically increases mortality in neonatal candidiasis. Coagulase-negative Staphylococcus stands as the most common late-onset sepsis pathogen in neonatal intensive care, requiring clinicians to understand both its unique characteristics and the diagnostic challenges it presents. This organism group represents a perfect example of how normal human flora becomes pathogenic in vulnerable populations. The predominance of coagulase-negative Staphylococcus in late-onset sepsis reflects several converging factors. These organisms, primarily Staphylococcus epidermidis, constitute normal skin flora that becomes problematic when protective barriers fail. Their success in the NICU environment stems from remarkable biofilm production capabilities on foreign surfaces, particularly central venous catheters and other medical devices. Understanding biofilm formation becomes crucial for recognizing why these infections prove so challenging to treat. When coagulase-negative Staphylococcus adheres to catheter surfaces, it produces extracellular matrix substances that create protective layers around bacterial colonies. These biofilms shield organisms from both immune system recognition and antibiotic penetration, creating persistent infection sources that continuously seed the bloodstream despite appropriate therapy. The diagnostic challenge involves distinguishing true infection from contamination, since these organisms normally inhabit skin surfaces. A positive blood culture for coagulase-negative Staphylococcus requires careful interpretation, considering clinical context, quantitative culture results, and growth from multiple blood draws. Single positive cultures often represent contamination from skin flora during venipuncture, while persistent positive cultures suggest true bacteremia. Risk factor patterns help identify vulnerable populations most likely to develop genuine coagulase-negative Staphylococcus infections. Central lines create the primary portal of entry, with infection risk increasing proportionally to catheter duration. Prolonged total parenteral nutrition provides both a foreign body surface for biofilm formation and nutritional substrates that support bacterial growth. Very low birth weight infants face highest risk due to immature immune systems, compromised skin integrity, and prolonged dependence on invasive devices. The therapeutic challenge emerges from widespread methicillin resistance, affecting approximately 80% of hospital-acquired coagulase-negative Staphylococcus isolates. This resistance pattern necessitates vancomycin as first-line therapy for suspected infections while awaiting susceptibility results. However, successful treatment often requires combining vancomycin with central line removal because biofilm-embedded organisms resist antibiotic clearance even with appropriate antimicrobial therapy. Treatment decisions involve balancing infection, eradication against device dependency. While line removal provides the most effective cure for catheter-related bloodstream infections, some critically ill infants depend on central access for survival. These scenarios require infectious disease consultation to optimize antibiotic selection, dosing, and duration while maintaining essential vascular access through alternative approaches. Staphylococcus aureus represents a dramatically different clinical challenge compared to the coagulase-negative staphylococci we discussed previously. Understanding the distinction between these organisms becomes critical because their virulence patterns, clinical presentations, and therapeutic requirements differ fundamentally. Unlike coagulase-negative Staphylococcus, which primarily causes indolent infections, Staph aureus demonstrates true pathogenic virulence that never represents contamination when isolated from blood cultures. This gram-positive organism arranges in characteristic clusters under microscopic examination and possesses multiple virulence factors that enable aggressive tissue invasion and systemic disease. The pathogenic arsenal of Staph aureus includes coagulase enzyme production, protein A within the cell wall, and numerous toxins that facilitate tissue destruction and immune system evasion. Protein A specifically binds immunoglobulin G antibodies, blocking normal immune recognition and bacterial clearance. This enhanced virulence explains why Staph aureus infections demonstrate more aggressive clinical courses than coagulase-negative species. Clinical presentations span a broad spectrum from localized skin infections to life-threatening systemic disease. Bacteremia frequently accompanies S. aureus infections and may persist despite appropriate antibiotic therapy, indicating the organism's ability to establish deep tissue foci or biofilm formation on foreign devices. Pneumonia can develop through either hematogenous spread or direct inoculation, often producing necrotizing lung damage. Skin and soft tissue infections represent common manifestations, ranging from superficial pustulosis to deep cellulitis requiring surgical intervention. The organism's ability to produce tissue-destructive enzymes creates the potential for rapid progression to deeper structures. Omphalitis, particularly in the setting of umbilical catheter placement, can serve as a portal for systemic infection. Musculoskeletal involvement demonstrates Staph aureus's predilection for deep tissue invasion. Osteomyelitis and septic arthritis require aggressive treatment because these infections can lead to permanent joint destruction and long-term disability. The organism's ability to adhere to bone matrix and establish biofilm formation makes eradication particularly challenging. Treatment decisions depend critically on methicillin susceptibility patterns. Methicillin-susceptible S. aureus responds well to nafcillin or oxacillin, which provide excellent anti-staphylococcal activity with narrow-spectrum coverage. However, methicillin-resistant Staph aureus requires vancomycin as first-line therapy due to resistance to all beta-lactam antibiotics. The therapeutic principle of foreign body removal becomes essential for Staph aureus infections involving central lines or other devices. Unlike some organisms where device salvage might be attempted, Staph aureus's aggressive virulence and biofilm-forming capacity generally mandate catheter removal for successful treatment. When devices cannot be removed due to clinical necessity, prolonged antibiotic courses and infectious disease consultation become critical for optimizing outcomes. Methicillin-resistant Staphylococcus aureus represents an escalating threat in neonatal intensive care units, demanding understanding of both epidemiologic patterns and aggressive control measures necessary to prevent devastating outbreaks in vulnerable populations. The distinction between hospital-associated and community-associated MRSA strains helps predict clinical presentations and therapeutic requirements. Hospital-associated MRSA emerges in patients with prolonged hospitalization and multiple antibiotic exposures, often demonstrating resistance to multiple drug classes beyond beta-lactams. Community-associated MRSA affects previously healthy infants and possesses enhanced virulence factors, particularly Panton-Valentine leukocidin toxin, which increases tissue destruction severity. Risk factor identification becomes crucial for targeting prevention efforts. Previous antibiotic exposure creates selective pressure favoring resistant organisms while suppressing protective flora. Prolonged hospitalization increases exposure time to resistant hospital flora during immune system compromise. Contact with colonized healthcare workers or family members represents the primary horizontal transmission mechanism. Infection control requires comprehensive interventions beyond standard practices. Active surveillance screening identifies asymptomatic carriers through nasal swabs on admission and at regular intervals. Contact isolation prevents spread through healthcare worker hands, requiring dedicated nursing assignments and strict personal protective equipment adherence. Cohorting strategies during outbreaks involve dedicated staff caring only for colonized patients. Decolonization protocols using topical mupirocin may reduce transmission risk, though resistance can emerge with overuse. Treatment challenges reflect limited antibiotic options and unique neonatal pharmacokinetics. Vancomycin remains the cornerstone therapy, but dosing requires careful attention to renal function maturation and therapeutic monitoring. Alternative agents like linezolid offer advantages but lack extensive neonatal safety data. Successful MRSA control demands institutional commitment to comprehensive infection prevention programs, integrating surveillance, rapid identification, appropriate isolation, and evidence-based treatment protocols while maintaining intensive care these vulnerable infants require. Klebsiella species stands as the second most common gram-negative rod, causing late-onset sepsis in neonatal intensive care, representing a formidable pathogen with distinctive clinical patterns and concerning antibiotic resistance trends that demand urgent recognition and appropriate management. This encapsulated gram-negative rod demonstrates particular virulence in the NICU environment, accounting for approximately 15% of neonatal nosocomial infections. The organism's success in hospital settings reflects its ability to survive on environmental surfaces, resist multiple antibiotics, and establish biofilm formation on medical devices. Understanding Klebsielle's clinical patterns helps clinicians recognize when this pathogen becomes likely and adjust treatment accordingly. Ventilator-associated pneumonia represents Klebsielle's most characteristic presentation, particularly in mechanically ventilated preterm infants. The organism demonstrates remarkable tropism for respiratory tissues, often producing severe necrotizing pneumonia with characteristic cavitation and lung destruction. This cavitary pattern distinguishes Klebsiella pneumonia from other bacterial causes and suggests more aggressive tissue invasion than typical pneumonia pathogens. Urinary tract infections comprise another major manifestation, with Klebsiella accounting for 7 to 40% of neonatal UTI cases. The organism shows particular association with vesicoreteral reflux and complicated urinary tract anatomy, suggesting enhanced ability to establish persistent infection in structurally abnormal systems. This association becomes important when evaluating infants with recurrent UTIs or those requiring urologic intervention. The emergence of extended-spectrum beta-lactamase production among Klebsiella isolates creates significant therapeutic challenges. These enzymes hydrolyze most beta-lactam antibiotics, including third-generation cephalosporins typically used for gram-negative coverage. ESBL-producing strains often demonstrate co-resistance to fluoroquinolones and aminoglycosides, severely limiting treatment options in neonatal populations where antibiotic choices already face pharmacokinetic and safety constraints. The mortality impact proves particularly sobering, with gram-negative infections carrying 3.5-fold higher death rates compared to gram-positive organisms. This increased mortality reflects both enhanced virulence and limited therapeutic options when resistance emerges. Klebsielle's ability to produce necrotizing infections, establish persistent bacteremia, and resist standard antimicrobials contributes to these concerning outcomes. Recognition patterns focus on mechanically ventilated infants developing progressive respiratory deterioration, particularly when chest imaging reveals cavitary changes or necrotizing pneumonia. Similarly, UTIs in infants with structural abnormalities or recurrent infections should raise Klebsiella suspicion. Early recognition becomes crucial because delayed appropriate therapy significantly worsens outcomes in these high-virulence infections. Enterococcus species represent a particularly challenging group of gram-positive organisms in neonatal intensive care because they share many characteristics with coagulase-negative staphylococci while possessing unique pathogenic features and concerning resistance patterns that demand special attention. Understanding the two primary species helps predict clinical manifestations and risk factors. Enterococcus faeculacea demonstrates particular tropism for the urinary tract, accounting for approximately 10 to 16% of neonatal UTIs as the third most common urinary pathogen. This species often causes less aggressive systemic disease, but can establish persistent bacteremia when associated with central line infections. Enterococcus faecium typically originates from gastrointestinal sources and shows stronger association with prolonged hospitalization and broad-spectrum antibiotic exposure. The biofilm production capability resembles coagulase-negative staphylococci, making these organisms particularly problematic with indwelling medical devices. Enterococci produce polysaccharide slime layers that adhere to catheter surfaces, creating protective matrices that shield bacteria from both immune system recognition and antibiotic penetration. This biofilm formation explains why enterococcal central line infections often require device removal for successful treatment. Clinical presentations span multiple organ systems, reflecting the organism's ability to establish infection at various sites. Central line-associated bloodstream infections represent the most common manifestation, typically presenting with subtle signs of sepsis rather than fulminant illness. Meningitis remains rare, but carries significant morbidity when it occurs, particularly in preterm infants with compromised blood-brain barrier function. The association with necrotizing enterocolitis reflects enterococci's role as normal intestinal flora that becomes pathogenic in vulnerable preterm populations. These organisms frequently colonize the preterm gut for prolonged periods, and abnormal colonization patterns may contribute to NEC pathogenesis through inflammatory pathway activation and mucosal barrier disruption. Vancomycin-resistant Enterococcus emergence creates substantial therapeutic challenges that require comprehensive infection control responses. VRE has appeared in multiple NICUs nationwide, reflecting selective pressure from vancomycin use and horizontal gene transfer between bacterial species. These resistant organisms often demonstrate additional resistance to ampicillin and gentamicin, severely limiting treatment options in neonatal populations. The infection control response to VRE requires strict isolation precautions, contact barriers, dedicated nursing care, and patient cohorting during outbreaks. Environmental contamination can persist for extended periods, making thorough cleaning protocols essential for preventing transmission. Active surveillance screening may identify asymptomatic carriers who serve as reservoirs for ongoing spread. Treatment decisions for VRE infections necessitate infectious disease consultation because therapeutic options remain limited and often lack extensive neonatal safety data. Alternative agents like linezolid, daptomycin, or quinupristin dalfopristine may provide activity against resistant strains, but dosing, efficacy, and safety profiles in neonates require expert guidance for optimal outcomes. Central line-associated bloodstream infections represent the most significant healthcare-associated infection challenge in neonatal intensive care, demanding comprehensive prevention strategies and systematic management approaches to protect vulnerable populations who depend on vascular access for survival. Understanding the epidemiologic prominence helps explain why CLABSI prevention receives such intensive focus in quality improvement initiatives. These infections account for the highest rates of nosocomial infection in NICU environments because virtually all critically ill neonates require central venous access for parenteral nutrition, medication administration, and frequent blood sampling. The extended duration of catheter placement, often weeks to months, creates sustained risk exposure that exceeds other healthcare settings. Prevention bundle implementation represents the cornerstone of successful CLABSI reduction programs. These evidence-based interventions target multiple failure points in the infection pathway. Sterile insertion technique requires maximal barrier precautions, including sterile gowns, gloves, masks, and large sterile drapes during catheter placement. This approach reduces bacterial inoculation during the high-risk insertion process when skin barriers are breached. Daily assessment of continued need prevents unnecessary prolonged exposure by ensuring catheters are removed promptly when no longer essential for patient care. This practice recognizes that infection risk increases exponentially with catheter duration, making timely removal crucial for risk mitigation. Documentation systems often include checklist prompts to facilitate consistent daily review processes. Proper site care involves standardized dressing protocols, antiseptic preparation techniques, and scheduled dressing changes using aseptic technique. The insertion site requires regular inspection for signs of infection, with transparent dressings enabling continuous visualization while maintaining sterile barriers. Chlorhexidine-based antiseptics demonstrate superior efficacy compared to iodine-based preparations for ongoing site maintenance. Hub decontamination addresses the high-risk connection points where medication administration and blood sampling create potential contamination pathways. Scrubbing catheter hubs with antiseptic before each access, allowing adequate contact time, and maintaining closed systems minimize bacterial introduction through these frequently manipulated surfaces. Diagnostic approaches require paired culture techniques to distinguish true bloodstream infection from contamination. Drawing cultures simultaneously from the catheter and peripheral venous sites, with quantitative or time-to-positivity differential analysis, helps confirm catheter-related infection versus coincidental bacteremia from other sources. This differentiation becomes crucial for determining appropriate management strategies. Treatment decisions often necessitate line removal when possible because biofilm formation on catheter surfaces creates persistent infection sources resistant to antibiotic therapy alone. The decision involves balancing infection clearance against vascular access needs, particularly challenging in extremely low birth weight infants with limited venous access options. When catheters cannot be removed immediately, prolonged antibiotic courses with infectious disease consultation optimize outcomes. The duration of therapy extends 10 to 14 days after documented clearance of organisms from bloodstream cultures, reflecting the time required to eradicate biofilm-embedded bacteria and prevent relapse. This extended treatment recognizes that catheter-related infections involve more than simple bacteremia, requiring sustained antimicrobial pressure to achieve cure and prevent complications. Late-onset sepsis empirical therapy requires a fundamentally different approach than early-onset disease because the pathogen landscape shifts dramatically from maternal flora to hospital-acquired organisms. Understanding these therapeutic decisions helps explain why clinicians must balance broad coverage against resistance concerns while maintaining options for rapid de-escalation. The standard vancomycin plus gentamicin combination provides rational coverage for the most common late-onset pathogens through complementary mechanisms. Vancomycin targets gram-positive organisms that dominate hospital environments, particularly coagulase-negative Staphylococcus species that account for approximately 50% of late-onset infections. Its excellent activity against methicillin-resistant organisms, both MRSA and coagulase-negative strains, makes it essential in hospital settings where resistance rates exceed 80%. Gentamicin provides the necessary gram-negative coverage that ampicillin cannot deliver in resistant hospital environments. This aminoglycoside demonstrates reliable activity against E. coli, Klebsiella, and other Enterobacteriaceae that cause approximately one-third of late-onset infections. The synergistic effect between vancomycin and gentamicin enhances bactericidal activity, particularly important for treating device-related infections where biofilm formation creates additional therapeutic challenges. Antifungal consideration becomes crucial when bacterial therapy fails to produce clinical improvement within 48 to 72 hours. 3 specific scenarios mandate antifungal evaluation. First, lack of clinical improvement despite appropriate antibacterial therapy suggests either resistant bacterial infection or fungal etiology. Second, prolonged antibiotic exposure combined with total parenteral nutrition creates the perfect environment for Candida overgrowth through suppression of competing bacterial flora and provision of glucose-rich growth medium. Third, thrombocytopenia serves as a particularly sensitive marker for fungal infection in neonates. Candida species demonstrate remarkable ability to cause platelet consumption through multiple mechanisms, including direct bone marrow suppression, consumption during disseminated intravascular coagulation, and immune-mediated destruction. When platelet counts drop below 100,000, especially in the setting of clinical deterioration, empirical antifungal therapy becomes strongly indicated. Local antibiogram data proves essential for guiding empirical choices because resistance patterns vary significantly between institutions and geographic regions. Some centers maintain low MRSA prevalence, allowing empirical use of nafcillin or oxacillin instead of vancomycin for suspected staphylococcal infections. Others face high rates of extended-spectrum beta-lactamase production among gram-negative organisms, necessitating carbapenem therapy rather than gentamicin. De-escalation strategies become possible once culture results provide specific organism identification and susceptibility patterns. This approach allows clinicians to narrow therapy from broad empirical coverage to targeted antimicrobials, reducing unnecessary antibiotic exposure while maintaining therapeutic efficacy. For example, methicillin-susceptible S. aureus infections can be switched from vancomycin to nafgilin, while susceptible gram-negative organisms may allow gentamicin discontinuation in favor of ampicillin. The timing of de-escalation requires balancing rapid narrowing against the risk of treatment failure. Most experts recommend waiting 48 to 72 hours to ensure clinical stability before making significant antibiotic changes, though susceptibility results may allow some modifications earlier when clinical improvement is evident. Systemic inflammatory response syndrome definition in neonates creates one of the most challenging diagnostic frameworks in critical care because normal physiological values change dramatically throughout neonatal development. Understanding this definition requires examining both the underlying pathophysiology and practical assessment complexities. The requirement for 2 abnormal criteria, with at least one being temperature or white blood cell count, reflects recognition that these parameters represent the most reliable indicators of systemic inflammation. Temperature dysregulation occurs when inflammatory cytokines disrupt hypothalamic control. However, neonates often present with hypothermia rather than fever, particularly preterm infants lacking mature thermoregulatory mechanisms. Heart rate changes provide insight into systemic stress, but interpretation demands understanding normal developmental patterns. Tachycardia represents the most common response, as cardiovascular systems attempt maintaining oxygen delivery during inflammatory stress. The two standard deviation threshold accounts for wide baseline variation across gestational ages. Paradoxically, bradycardia can indicate severe illness in preterm infants, representing impending cardiovascular collapse. Respiratory changes encompass tachypnea from increased metabolic demands and mechanical ventilation recognition. Inflammatory responses increase oxygen consumption while impairing gas exchange through pulmonary edema and ventilation perfusion mismatch. Including mechanical ventilation acknowledges that critically ill infants may not demonstrate tachypnea because respiratory drive receives artificial support. White blood cell abnormalities provide crucial immune system activation information. Criteria include both abnormal total counts and greater than 10% immature forms. This left shift indicates bone marrow mobilization of immature neutrophils to combat infection. The immature to total ratio becomes valuable because it can remain elevated even when total counts appear normal. The fundamental challenge involves applying age-appropriate normal values across neonatal development spectrum. A heart rate of 180 might represent severe tachycardia in term infants, but fall within normal limits for 28-week preterm babies. This variation necessitates gestational age-specific nomograms and careful individual patient consideration. Suspected or proven infection distinguishes SIRS from sepsis, though clinical distinction becomes blurred. SIRS represents inflammatory response from various insults, including infection, trauma, or tissue injury. When infection is suspected, the syndrome becomes sepsis. Practical application requires integrating multiple data points while considering clinical context. The framework provides standardized research criteria, guides treatment intensity, and offers prognostic information, but clinical judgment remains paramount over rigid rule application. The inflammatory cascade in sepsis represents one of the most complex and devastating biological processes in critical care medicine, transforming a simple bacterial challenge into a life-threatening systemic crisis through a series of interconnected molecular events that can quickly spiral beyond the body's control mechanisms. Understanding this cascade begins with recognizing how bacterial endotoxins, particularly lipopolysaccharide from gram-negative organisms, trigger the initial inflammatory response. When these molecular patterns are recognized by immune cells, they activate toll-like receptors that serve as the body's danger detection system. This recognition immediately triggers the release of tumor necrosis factor alpha, the primary inflammatory mediator that acts as a molecular alarm signal throughout the body. TNF-alpha serves as the master switch that amplifies the inflammatory response by stimulating the production of interleukin-1, creating a cascade effect where one inflammatory signal triggers increasingly powerful downstream responses. Think of this like an avalanche, where a small disturbance triggers progressively larger and more destructive events. IL-1 further enhances the inflammatory response while also activating fever pathways and altering vascular permeability. Complement activation represents another crucial amplification mechanism where a series of plasma proteins become sequentially activated, creating powerful inflammatory mediators and membrane attack complexes that can damage both bacterial cells and host tissues. This system, designed to eliminate pathogens, can become destructively overactive during sepsis. The coagulation cascade becomes dangerously activated through multiple pathways, leading to widespread microthrombi formation that impairs tissue perfusion while simultaneously consuming clotting factors and platelets. This creates the paradoxical situation where patients develop both clotting and bleeding simultaneously, known as disseminated intravascular coagulation. Nitric oxide production by endothelial cells causes profound vasodilation that contributes to the characteristic hypotension seen in septic shock. While nitric oxide normally helps regulate blood flow, excessive production during sepsis creates vasodilation that cannot be overcome by normal compensatory mechanisms. Capillary leak syndrome develops as inflammatory mediators damage endothelial tight junctions, allowing fluid and proteins to leak from the vascular space into tissues. This creates tissue edema while simultaneously reducing intravascular volume, compounding the cardiovascular instability. The clinical progression from SIRs to sepsis occurs when infection is identified as the inflammatory trigger. Severe sepsis develops when organ dysfunction appears, indicating that the inflammatory response has begun causing tissue damage beyond the primary infection site. Septic shock represents cardiovascular failure requiring vasopressor support, while multiple organ dysfunction syndrome indicates that the inflammatory cascade has overwhelmed the body's compensatory mechanisms across multiple organ systems. Without intervention, this progression leads to irreversible organ failure and death. This cascade explains why early recognition and intervention becomes so crucial in sepsis management, as each stage represents an opportunity to interrupt the inflammatory amplification before it becomes self-sustaining and ultimately fatal. Septic shock pathophysiology reveals how the body's response to overwhelming infection can create two dramatically different clinical presentations that require entirely different therapeutic approaches. Understanding these patterns helps explain why neonatal septic shock can appear so variable and why treatment strategies must be tailored to the specific hemodynamic profile. The fundamental definition centers on inadequate tissue perfusion, meaning that despite the heart continuing to beat and blood continuing to circulate, oxygen and nutrients cannot reach tissues effectively enough to maintain cellular function. Think of this like a city where the roads still exist, but traffic flow has become so disrupted that essential supplies cannot reach their destinations. Cold shock represents the more common pattern in neonates and reflects the body's attempt to preserve blood flow to vital organs by sacrificing perfusion to less critical areas. When the cardiovascular system recognizes inadequate blood pressure, it responds by increasing vascular tone through intense vasoconstriction. This creates the characteristic findings of cool extremities, as blood flow is redirected away from arms and legs toward the brain, heart, and kidneys. The increased vascular resistance forces the heart to work against higher afterload, but in the setting of sepsis-induced myocardial depression, cardiac output actually decreases, rather than compensates appropriately. This creates a vicious cycle where poor cardiac function leads to more vasoconstriction, which further impairs cardiac output. Clinically, these infants appear pale, cool to touch, and demonstrate weak peripheral pulses despite potentially normal blood pressure measurements. Warm shock presents an entirely different pathophysiologic pattern where overwhelming vasodilation becomes the dominant feature. Here, the inflammatory cascade produces such intense nitric oxide release and direct vascular smooth muscle damage that blood vessels cannot maintain normal tone despite compensatory mechanisms. The result resembles a garden hose with multiple holes, where despite high flow, effective pressure cannot be maintained. In this scenario, the heart actually increases its output in an attempt to compensate for the dramatically reduced vascular resistance. This high output state creates the paradoxical situation where cardiac function appears robust while tissue perfusion remains inadequate. These infants present with warm extremities, bounding pulses, and characteristically wide pulse pressure as the difference between systolic and diastolic pressures increases significantly. Understanding these two patterns becomes clinically crucial because they require opposite therapeutic approaches. Cold shock benefits from afterload reduction and inotropic support to improve cardiac output, while warm shock requires vasopressor agents to restore vascular tone. Applying the wrong treatment can worsen the underlying pathophysiology rather than correct it. The transition between these patterns can occur during the course of illness, making continuous assessment essential. Some infants begin with cold shock and progress to warm shock as myocardial function improves, but vascular damage worsens. Others may demonstrate mixed patterns where different vascular beds show different responses simultaneously. Recognition of these patterns helps clinicians anticipate treatment needs and monitor response to interventions, ultimately improving outcomes in this most critical phase of neonatal sepsis. The phases of shock represent one of the most critical concepts in understanding how the body responds to severe stress. And recognizing these stages can literally mean the difference between life and death in clinical practice. Think of shock as the body's progressive inability to maintain the delicate balance between oxygen supply and demand at the cellular level. The compensated phase demonstrates the remarkable resilience of neonatal physiology through an impressive array of protective mechanisms. During this stage, the body recognizes that something is wrong and immediately activates its emergency response systems. Blood pressure remains normal because the cardiovascular system successfully redirects blood flow away from less essential areas like skin, muscle, and gastrointestinal tract toward the brain, heart, and kidneys. Consider this like a city during a crisis where emergency services prioritize protecting the most critical infrastructure first. The increased heart rate represents the cardiovascular system working harder to maintain adequate circulation despite the underlying problem. Meanwhile, peripheral vasoconstriction ensures that available blood volume reaches vital organs, even as overall cardiac output may be declining. The early development of lactic acidosis provides crucial insight into what's happening at the cellular level. When tissues don't receive adequate oxygen, cells must switch from efficient aerobic metabolism to much less efficient anaerobic pathways. This process produces lactic acid as a waste product, creating the measurable laboratory finding that often serves as the first objective evidence that shock is developing, even when vital signs appear stable. The transition to uncompensated shock marks the point where the body's protective mechanisms become overwhelmed and can no longer maintain normal blood pressure. This represents a critical turning point because once hypotension develops, the downward spiral typically accelerates rapidly. Now even vital organs begin receiving inadequate perfusion, creating a dangerous situation where the brain, heart, and kidneys start failing simultaneously. The metabolic acidosis becomes more severe during this phase as increasing numbers of cells resort to anaerobic metabolism. Think of this as the cellular equivalent of running up debt. The longer tissues operate without adequate oxygen, the more metabolic waste products accumulate, creating an increasingly hostile internal environment that further impairs cellular function. Understanding the progression to irreversible shock helps explain why early recognition and aggressive intervention prove so crucial in sepsis management. Once multiple organ systems begin failing, the damage becomes self-perpetuating. Failed kidneys cannot clear metabolic waste products, damaged hearts cannot pump effectively, and compromised lungs cannot provide adequate oxygenation. Even if the original infection is controlled, the cascade of organ dysfunction continues independently. The concept of irreversibility doesn't mean immediate death, but rather indicates that normal cellular function cannot be restored even with optimal treatment. This explains why prevention and early intervention strategies focus so intensively on recognizing and treating shock during the compensated phase, before the process becomes self-sustaining and ultimately fatal. Shock management in neonates requires understanding why time becomes the enemy and how each intervention targets specific aspects of the failing cardiovascular system. Think of shock as a house fire, where every minute of delay allows more damage to occur, making the golden hour concept absolutely critical for preventing irreversible harm. The first hour represents the window during which interventions can still reverse the shock process before organ damage becomes permanent. During this critical period, the body's compensatory mechanisms are still functioning, meaning that aggressive support can restore normal physiology rather than simply slow, inevitable deterioration. This timing explains why sepsis protocols emphasize immediate recognition and rapid intervention rather than lengthy diagnostic workups. Volume resuscitation forms the cornerstone of initial shock management because most neonates in septic shock suffer from relative or absolute hypovolemia. The inflammatory cascade causes massive capillary leak, allowing fluid to escape from the vascular space into tissues where it cannot contribute to circulation. Normal saline or lactated Ringer's solution provides isotonic fluid replacement that stays within the vascular compartment longer than hypotonic solutions. The approach of giving 10 to 20 milliliter per kilogram boluses allows clinicians to assess response incrementally rather than overwhelming the cardiovascular system. Think of this like slowly filling a leaky bucket. You need to add fluid faster than it's escaping, but adding too much too quickly can cause overflow problems. Many septic neonates require up to 60 milliliters per kilogram total, which represents nearly 20% of their total blood volume, demonstrating how severe the fluid losses can become. Correcting hypoglycemia becomes crucial because the brain depends almost entirely on glucose for energy, and shock states dramatically increase metabolic demands while impairing glucose delivery. Neonates have limited glycogen stores and high glucose utilization rates, making them particularly vulnerable to hypoglycemia during stress. Similarly, hypocalcemia correction proves essential because calcium plays a vital role in cardiac muscle contraction, and sepsis often causes calcium levels to drop through multiple mechanisms. The 1-hour antibiotic deadline reflects understanding that bacterial multiplication occurs exponentially, meaning that each hour of delay allows the infectious burden to increase dramatically. Early source control, eliminating the bacteria driving the inflammatory cascade, can prevent progression to irreversible shock. Broad-spectrum coverage ensures that empirical therapy addresses the most likely pathogens while culture results are pending. Hydrocortisone consideration for catecholamine-resistant shock addresses the possibility of relative adrenal insufficiency. The adrenal glands normally produce cortisol in response to stress, but overwhelming sepsis can exhaust this response. When standard vasopressor medications fail to restore blood pressure, hydrocortisone can provide the missing corticosteroid support that allows other interventions to work effectively. Understanding this protocol helps explain why sepsis management requires such coordinated, time-sensitive interventions, rather than the sequential approach used for less critical conditions. Vasoactive support represents one of the most complex aspects of shock management because each medication acts differently on the cardiovascular system, requiring clinicians to match the specific drug to the underlying pathophysiologic problem. Understanding this approach helps explain why medication selection becomes so crucial for successful outcomes. Think of the cardiovascular system like a complex plumbing network, where you need to balance both the pump strength and the pipe diameter to maintain adequate flow. Different shock states create different problems within this system, requiring different pharmaceutical solutions to restore normal function. Dopamine serves as the first-line agent because it provides dose-dependent effects that can be titrated to match patient needs. At lower doses, around 5 to 10 micrograms per kilogram per minute, dopamine primarily stimulates dopamine receptors that improve renal blood flow and may enhance urine output. As doses increase to 10 to 20 micrograms per kilogram per minute, beta-adrenergic effects predominate, increasing heart rate and cardiac contractility to boost cardiac output. At the highest doses, alpha-adrenergic effects cause vasoconstriction that can help restore blood pressure. Epinephrine provides the most versatile option because it addresses both cardiac and vascular problems, depending on the shock pattern. In cold shock scenarios where poor cardiac output represents the primary problem, epinephrine's powerful beta-adrenergic effects dramatically improve heart muscle contractility while also increasing heart rate to boost overall cardiac output. Think of this like upgrading both the engine power and transmission in a car that's struggling to climb a hill. For warm shock patients where excessive vasodilation creates the main issue, epinephrine's alpha-adrenergic effects provide the vasoconstriction needed to restore normal vascular tone. This represents fixing the plumbing system by tightening pipes that have become too loose to maintain pressure. Norepinephrine becomes particularly valuable in warm shock because it provides potent alpha-adrenergic vasoconstriction with minimal beta effects. This allows clinicians to restore blood pressure without excessively stimulating an already hyperactive heart, making it ideal when cardiac output is adequate, but vascular resistance has collapsed. Milrinone offers a completely different mechanism as a phosphodiesterase inhibitor that improves cardiac contractility without increasing heart rate, while simultaneously causing vasodilation. This combination proves particularly useful when cardiac dysfunction represents the primary problem, but excessive vasoconstriction is making the heart work harder than necessary. Vasopressin serves as the rescue agent for refractory shock that doesn't respond to conventional medications. This hormone works through completely different receptors to cause vasoconstriction, often succeeding when other agents have failed. Think of this as having a backup electrical system when the primary power fails. Echocardiography monitoring provides real-time visualization of cardiac function, allowing clinicians to assess whether interventions are improving contractility, reducing afterload, or optimizing preload. This imaging guidance helps explain why certain medications work better than others in individual patients, enabling more precise therapeutic adjustments than vital signs alone could provide. Extracorporeal membrane oxygenation represents one of the most sophisticated life support technologies available in modern medicine, essentially functioning as an artificial heart and lung system that can maintain circulation while the body's own organs recover from severe injury. Understanding ECMO requires examining both its incredible capabilities and the careful selection criteria that determine when this extraordinary intervention becomes appropriate. Think of ECMO as creating a temporary bypass around failing organs, similar to how cardiac surgeons create bypass grafts around blocked arteries. The system removes blood from the patient's body, oxygenates it through an artificial membrane, removes carbon dioxide, and returns the treated blood back to circulation. This process can completely replace heart and lung function for days or weeks, providing time for recovery that would be impossible with conventional support alone. The gestational age criterion of 34 weeks reflects the balance between viability and bleeding risk. Before 34 weeks, the combination of immature coagulation systems and the necessary anticoagulation for ECMO creates prohibitive bleeding complications. The brain's fragile vasculature in extremely preterm infants cannot tolerate the anticoagulation required to prevent clotting in the artificial circuit, making ECMO too dangerous despite its potential benefits. The requirement for a reversible process represents perhaps the most critical selection criterion because ECMO provides support, not cure. The underlying condition must have realistic potential for recovery, whether that involves clearing an overwhelming infection, allowing injured lung tissue to heal, or providing time for cardiac function to improve. Without reasonable expectation of recovery, ECMO simply prolongs suffering rather than providing meaningful benefit. Failed maximal medical therapy ensures that ECMO is reserved for situations where conventional intensive care has proven inadequate. This includes optimal mechanical ventilation, maximal vasoactive support, appropriate fluid management, and aggressive treatment of the underlying condition. ECMO should represent the next step in escalation rather than an early intervention, given its complexity and associated risks. The contraindications help identify patients unlikely to benefit from this intensive intervention. Grade 3 or 4 intraventricular hemorrhage indicates significant brain injury that may be irreversible and could worsen with the anticoagulation required for ECMO. Irreversible organ damage suggests that even if ECMO successfully supports circulation, the patient cannot return to meaningful function. Severe coagulopathy creates bleeding risks that may prove fatal when combined with the mandatory anticoagulation. Understanding why survival rates reach 70 to 80% for septic shock helps put this intervention into perspective. These outcomes reflect both careful patient selection and the remarkable ability of young patients to recover from severe illness when provided adequate support. The success rate also demonstrates that septic shock, unlike some other conditions requiring ECMO, often represents a potentially reversible process where temporary mechanical support can allow natural recovery mechanisms to succeed. The decision to initiate ECMO requires weighing extraordinary potential benefits against significant risks and resource utilization, making it one of the most complex decisions in neonatal intensive care.